Welcome to this webinar, and thank you for being with us this afternoon, in which we'll be hearing from the lead author of a report from the London School of Hygiene and Tropical Medicine entitled Crisis in Gaza, Scenario-Based Health Impact Projections. The goal of this report has been to project the number of excess deaths over the next few months in the Strip based on a variety of scenarios. My name is Brandon Marshall, and I'm a professor of epidemiology at the Brown University School of Public Health. I'm also the founding director of the People, Place, and Health Collective, a research program at Brown that is hosting today's webinar. I'd like to start by welcoming members of the Brown community and members of the public for joining us today. I'd also like to thank the Brown University School of Public Health's Office of Diversity, Equity, and Inclusion, as well as the Brown University Center for Middle Eastern Studies and the New Directions in Palestinian Studies programs for co-hosting today's webinar. We're holding this webinar in the spirit of Brown University's mission of advancing knowledge and understanding within a respectful, open, and inclusive environment. Over the last few months, we've witnessed a catastrophic man-made public health crisis develop in the Gaza Strip. The director of the World Health Organization noted in remarks to the UN in December that alongside the displacement of almost the entire population of Gaza, overcrowding, inadequate food, water, shelter, and sanitation are creating the ideal conditions for vector-borne and gastrointestinal diseases. Reports from the United Nations Integrated Food Security Phase Classification Program has repeatedly stated that Gaza is facing catastrophic hunger and famine, with the chief economist and director of the World Food Program calling the situation unprecedented. The International Court of Justice, which is the world's highest profile international tribunal, ruled unanimously on March 29th that Israel must take all necessary and effective measures to ensure, in full cooperation with the United Nations, the unhindered provision at scale by all concerned of urgently needed basic services, including food, water, shelter, and fuel, as well as medication and sanitation supplies. All of this comes on top of a growing death toll as a result of the war. Since October 7th, more than 30,000 Palestinians and 1,200 Israelis have been killed in this conflict, and the number of Palestinians experts believe is likely an undercount. The report we'll be hearing about today is aimed to estimate the public health impact of this crisis under different future trajectories of its evolution. The report also identifies the leading causes of excess deaths under each scenario. And you can read the report at gaza-projections.org. It's now my great pleasure to introduce our speaker this afternoon, Zeina Jamaluddine, who's a nutritionist, epidemiologist, and research fellow at the London School of Hygiene and Tropical Medicine. Her research focuses on child and household level food insecurity, water insecurity, and malnutrition among refugees and marginalized populations in the Middle East and North African region. Zeina's current PhD thesis focuses on establishing a Palestinian birth cohort using electronic health records. Ms. Jamaluddine will speak for about 35 minutes, following which we'll have plenty of time for questions from the audience. If you have questions for the presenter, please use the Q&A box, and we'll do our best to get to them during the discussion. I want to note that the chat and raise hand feature is disabled in the webinar format, so please use the Q&A for your questions. So without further ado, I'll pass it over to Zeina, who will walk us through the report and the findings. Over to you, Zeina.
Thank you, Brandon, and thank you everyone for the invite, and look forward to presenting around 35 minutes, and then actually look forward more for the Q&A discussion. So please write them in the chat box, and not the chat box, the Q&A actually, and I'll try to answer most of them. So have some slides. I'll go over them for around 35 minutes. And just to say that, to start off, is that we attempted basically in December, January, to actually look at what are the different scenarios in terms of health that's going to come and projections in Gaza. Specifically, as Brandon mentioned, the healthcare system collapsed in December. And so we know that this has a huge implication on public health, and we wanted to quantify this. And so we started off with a team between London School of Hygiene and Johns Hopkins University to really try to do these estimates. And I need to start off by actually acknowledging that the numbers that people are seeing from the Ministry of Health are people who are killed from traumatic injuries. And today we are more at 33,000, and this number is just keep increasing. And before we talk about all the numbers, and I'll be talking a lot about numbers, I just want to take a moment to mention that here we're talking about people behind these numbers, doctors, university professors, poets, journalists, and this has a huge, huge human toll on children. And these are names of some few of them, of the 33,000. With one poet who talked about building in heaven a city, a new city of Gaza, and Hiba, who was also killed. So just this moment to talk that there are people behind these numbers, and moving forward with the aim of the objective of the project was really to inform humanitarian response of where the aid is, but also diplomatic efforts to see what different scenarios is going to lead to different things. Now, we have built a scenario that things are changing on the ground. However, it also presents an idea of where the human toll is going to be. And we used mortality as an end stage of most downstream indicator of the public health, although we know that the war will have a lot of morbidities and other aspects that we did not project. We also look at excess mortality, that means over and above what would have happened during this period. So we know that a certain period there would be mortality from infant mortality, neonatal mortality. This is stuff that happened before the war, but then excess mortality that we refer to always is actually over and above what would have usually happened because of lack of access to care. And we have ethical approvals, and actually everything is available on our website and on GitHub, so people can reproduce. And there's a detailed methods annex that I won't go in detail when I present today, but people are free to go in, and actually like things are being always updated, and we are trying to update even the methods. So if people have suggestions, we're happy to collaborate. And we have like Brandon mentioned, a website, and this is a QR code for the website, but also an email, and you can email. And move forward is to say that when we started the work, we wanted to really see 3 different scenarios that would go moving forward. What would happen using these 3 scenarios? A permanent ceasefire for the next 6 months, and actually permanent. And then we projected also a status quo scenario, which was actually the period between October and January, and an escalation scenario. The escalation scenario was a full-on attack on Rafah. And basically what would happen in terms of projections of mortality under these 3 scenarios. We have used to generate the scenarios, understanding the military activity, the population movement, whether during the status quo, whether there would be those humanitarian pause or not, as it happened one time before for a very short period of time, and then whether in an escalation no humanitarian pause is happening, and then also what would happen in terms of the humanitarian response. So if people are able to go in, and hospitals, what happened to the hospitals? Any field hospitals are being, we used all of these variables to look at the 3 different scenarios. We looked at projections for the next 6 months, and we did then talk about, when we talk about wars, okay, we have aerial and ground warfare that leads to traumatic injuries and direct deaths from that. And this is what was happening, especially at the beginning of the war. However, with the deterioration of the healthcare system, with also the attack around and in healthcare systems and disruptions of healthcare services, the poor shelter conditions that increased exponentially as we move forward in the conflict, in the war, the insufficient water and sanitation, and the insufficient food, all of these would lead to the indirect effects of the war, of mortality, of excess mortality, of things that could have been treated. And all of that could be all compounded with even more by basically an epidemic. So if an epidemic occurs, things would exponentially increase. So far, we have not seen an epidemic occur, and hopefully we won't. But the whole situation on the ground is moving towards this aspect. And so moving forward is what we tried to project was actually traumatic injuries, like I mentioned, dying immediately from your wounds or dying immediately from the exposure to the war, but also untreated wounds. So you go to the hospital, but there is no availability to treat. So things that could have been treated that were not treated. Infectious diseases, we actually separated them into two in terms of a bit endemic and epidemic, just because Gaza had a very high vaccination rate. And we wanted to see what would happen with the decrease in vaccination and to look at airdrop droplet transmission, but also fecal oral transmission. We also did another one related to epidemic because basically focusing on cholera and meningitis, and I will explain more why we separated them also later. We then did a model for the maternal newborn excess mortality and stillbirth, and this is basically linked to not traumatic injuries from moms being exposed to the war, but rather from not being able to access healthcare services. And finally, increased mortality from NCDs. We have done projections of malnutrition, and I will present it, but we used it as an underlying risk factor for all the others' mortality. And we were not able to actually do increased mortality from diabetes type 2 and COPD, which is a chronic obstructive pulmonary disease, because mainly the literature that we needed for that specific was not available. And some of the elements about accidents and some basically some cardiovascular diseases other than ischemic heart diseases, we were not able to really put in. So the NCD model is probably an under reporting of what's happening in the situation. And I would explain this also. So in order to do all of that, we need to first start by understanding what data is available. As someone who has worked in this region or other conflict, I can tell you Gaza is very data heavy and data rich, even before the war. We knew exactly from UNRWA, the UN agency that works with Palestinian refugees and provides them with primary health care, with WHO and the Ministry of Health, there has been very good documentation. So we before the war, but then during the war, we relied on data that came out from UN agencies and from different actors on the ground. We then also had to rely, like I mentioned, on peer-reviewed articles and on expert citation and consultation to get information for some effect size and on some elements in the models. And then we will continue updating, as I mentioned. And I think I've not seen this done actively in the middle of war to try to project all different causes of death. And so I think this exercise is one of the first that's been trying to do something during a war happening, but also these are methods that we've had to develop, most of them in-house. So I won't go at all in the details of the methods, just to say that except for the maternal newborn model, all other traumatic injury, infectious diseases, NCDs, and also was actually developed during December and January. And so we wanted to see how, for example, and for the maternal newborn projections, we actually used we used the LifeSafe tool. That's actually a very well-established model that looks at services available and how much you would increase services, so maternal care or access to hospitals, and how much that saves lives. Instead of saving lives, we looked at the opposite of how much lives would be killed or if the reduced services actually happen. And so instead of looking at increase in coverage, we decreased the coverage of interventions and life-saving interventions. We then included all of those together in a model and basically ensured that a person cannot die twice from different causes, and applied some reductions and basically come up with these projections. And as I mentioned, for background data or data about what happened before the war, we relied on data from the Ministry of Health, but also from UNRWA. And then for the data on risk factors on during the war, we used what's happening currently on the ground. And this is an example of some of the elements we included in the models. So as I mentioned, sorry, I'm moving quickly. As I mentioned, we have a ceasefire scenario, we have a status quo scenario, and we have an escalation scenario. And in order to actually understand how to include the risk factors in the models, we used some to understand the water situation. So how many liter per person per day people have access to. In the status quo, it was around actually 6 to 10% of liter per person per day. There's some indication now that actually we're even moving towards 3 to 6 liters per person per day, and fitting in an escalation scenario of the water situation. And hopefully with a ceasefire and with a humanitarian access, we could increase the water availability. Just to say that according to SPHERE and UNHCR, the minimum standards of water survival water is actually 15. So we're already below that number. We then used also numbers related to how many people are using one toilet. For example, in the status quo, there's around 400 to 800 people in different shelters using one toilet. And different indicators about shelters, crowdiness, and all of the situation. We also relied on data on healthcare system disruption. So how many healthcare system hospitals are working, how many primary healthcare centers are available, and people access to these. And we included them in the infectious disease model, the maternal newborn, the NCD, and so on. And so we made these assumptions and used the epidemiological risk factor and the healthcare service disruption in order to come up with these projections. Now, just to say that this is projections, not predictions. And so at the end of the day, we are showing what are happening in different scenarios. And one key element is to say that even with a ceasefire scenario, we are projecting around 11,000 excess mortality in case of an epidemic. And I will explain this in the infectious disease model. And in case of an escalation, we project around 85,000 excess mortality in case of an epidemic. And this is moving forward, as I mentioned. So then we also look at, for example, what will happen in a ceasefire scenario, which is in the light green, and an escalation scenario, which is in purple, in terms of mortality risk by age groups. So if you look at the different age groups over time, the numbers that are inside the graphs show how many times more likely to die as opposed to before the war. And you would see numbers of around like 300 in an escalation scenario of around 3,000 times more likely, for example, in children aged 10 to 14, which is usually not an age group where we would see high rates of mortality before the war. And just for humanitarian actors, this is something that they tend to use more, is actually crude death rate per 100,000, per 10,000, sorry. So crude death rates per 10,000 person day. And in what you'll see in light green is actually the ceasefire scenario, and in the purple is the escalation scenario, and in gray is always what would be expected before the war. So this mortality of baseline of people who are going to die during that year is always in, but then we project the excess of it. And so you'd see that there's an increase by 7 times of excess mortality in a ceasefire, and in an escalation around 43 times more likely to die. So in terms of model-specific mortality, the trauma one is one where we're talking about direct mortality from death. I think we mentioned that the numbers of the Ministry of Health, there's some underreporting with that because of the fact that people are under the rubble, not been able to take out. They were not able to go to the hospital, and so some of the people who didn't arrive to the hospital and died at home were actually buried right away. And so these numbers are not included in the Ministry of Health reporting. And so what we ended up doing is we took the Ministry of Health numbers of reported mortality. We also looked at mortality from UNRWA, the UN agency that works with Palestinian refugees, and look at the death rates and use that as a way to actually project what is the proportion of people that might not have been counted, mainly because you wouldn't expect that there is a higher targeting of UNRWA workers rather than people than the normal population. And so we estimated this mortality and used that for the projections. We also looked at the location of some of the injuries and basically used the mortality rates in terms of the locations and estimated some of these proportions. And in a ceasefire scenario, we also included people dying from their wounds because of untreated wounds, but also we included unexploded ordnance, because usually this is what happens in wars with a ceasefire. People go back to the houses and get exposed to what's left behind, and there's mortality that comes with that. So just to say that these are some of the projections of the excess mortality. The light, you can see that there is increased mortality in the ceasefire scenario, but also in the escalation scenario. But what the colors here actually mean is that the light is actually immediate death, whereas the darker color represents dying from wounds that were untreated. So those who were delayed with treatment, and there is quite a few that could be saved if there is access to hospitals, to field hospitals. That's becoming even more hard as we move forward. We also looked at the mortality from traumatic injuries in the status quo, in the current situation. And you could see that actually in the colored bar graphs and the pyramid is actually the mortality that happened from the traumatic injuries. And we overlaid it in these pyramids that are actually not colored. You can see there's an overlay of 2 pyramids here. And the pyramid that is uncolored is actually the mortality, the population pyramid before the war. And you could see that the majority of the people who are killed are actually children and women. And also you'd see that they represent a lot the population before the war. But also there is a bulge among men of age 20 to 35, partly maybe because they're the fighters, but also because they're the ones who are firstly going to get food, to get care, and so they're more exposed to the war. Then moving forward with, I think what's happening currently with most urgency is the malnutrition projections. I just want to start with the fact that when we did that projection, we did it in February and things changed, and we are updating this. And if you, in the next 10 days, if you check the website, there would probably be another update. But just to say that at that time, around 5,300 food-only trucks reached Gaza. During that period, there would be around 17,000 to 20,000 food trucks that would have expected to enter. So there is already a huge deficit. What we ended up doing is we looked at the food trucks, and this is the first graph, is mapping the food trucks. And then what we did is we translated it to how much calories is coming into Gaza. And we used what's available in the market, what's available in houses and stores and all of that, and projected later on how much, for example, calories are available per capita per person, and use this deficit to model the percent weight loss among adults, and then use that to project acute malnutrition, which is also what's being reflected as wasting or very, very thin children, and to look at how much malnutrition is going to increase. And so just to start off, you start to hear a lot from people saying that people lost 20 kilos or 15 kilos, especially adults. You start hearing a lot of this now. And so at the beginning of the war, people were not losing weight, so 0% weight loss. And then at a certain point, we start seeing weight loss. And then we use that to project 3 scenarios. The first scenario is actually an escalation, a ceasefire scenario, actually saying that food came back and we are there's food coming in. In the status quo, that at that point, things were going back in. So, and an escalation scenario is where food actually decreased. And what's important to say is that after we did these projections, food significantly decreased from coming in, and now they backed up and came back in. But not to the level that needs to come in. And we can discuss this further if you guys want. But just to say that we're currently in 100% in an escalation scenario of the malnutrition, where actually you see acute malnutrition currently with kids dying from acute malnutrition. So before the war, the prevalence of malnourished children was around 3%. Up to February, it was around 14%, and in a status quo, in 1 to 3 months, it was actually like 16%. In an escalation scenario, it was like 25%. I have to tell you today that the data coming from the north is saying numbers of around 30% of acute malnutrition among children. And this is important because the IPC and the famine reports classify that any number above 30 is actually a classification of a famine. And so we're currently starting to see these numbers in the north. That was back in March. The situation, if it does not get intervened immediately, things can increase exponentially as we move forward. I will continue with the other models, but if any questions on the malnutrition, I can talk further on, happy to answer. In terms of the infectious disease, which actually fits right into the malnutrition, as I mentioned, all the numbers we're seeing from the Ministry of Health are not about non-traumatic death. So before the war, actually, infectious disease was not an issue except for COVID-19. So before, the mortality from infectious disease, you can see over the years, was very low. But then in 2020 and 2022, COVID-19 hit. And so we had excess mortality from COVID-19, and then a decrease with vaccination. And what we did is actually build dynamic cohort models to track immunity to infection. So basically, and diseases. We looked at vaccine coverage, effectiveness, the natural pre-war exposure to infections. And then we modeled also the endemic infectious diseases. And later on, we also modeled epidemics separately. We used expert elicitation to quantify the probability of an epidemic because we're not sure like if an epidemic is going to occur. And so we relied on information from 7 different key informants, and also looked at transmissibility using basic reproductive numbers, case fatality ratio, and different indicators from expert elicitation, but also from the literature, and use all of these to come up with the excess mortality. Now, we projected that actually the biggest mortality is coming from influenza and pneumococcal diseases and COVID-19, because also like vaccination was happening in Gaza, but not fully. And then you could see that we tried to model it with the seasonality effect. So we know that influenza is very seasonal based. So now, as we move forward now to the summer, this will become less of an issue. But when we talk about epidemics, which is basically where the biggest number of infectious disease happen, we actually project overall around 5,000 excess deaths in a ceasefire from only epidemics, and in an escalation around 11,000. And this has uncertainty because this is all dependent on the probability of an epidemic occurring. So cholera is not in Gaza, and so if there's if this starts to occur, then this is where we will have very high rates of very high prevalence and incidence. Sorry, I think up. We'll see very high excess mortality from cholera outbreak, and so that could reach up to 120,000. So, and here we show the probability of them occurring under 3 scenarios. And it's around like 15 to 20%. And as we move forward, things are becoming more detrimental to this. And the big threats are cholera, measles, polio, and meningitis. As we move also to the maternal newborn model, as I mentioned, for this model, we actually relied on the LifeSafe tool that looks at antenatal care, so women are able to access antenatal care before delivery, healthcare facilities that would provide a service, life-saving interventions for pregnant women in terms of C-section, but also in terms of blood transfusion, and then also for newborn care. So whether it's like availability of NICUs and clean birth space and neonatal resuscitation and so on. We also relied on information on breastfeeding because, in fact, this will have an increased mortality for children that are not being able to be breastfed. And we know that from data in the region and previous wars in the region, and also given the situation in wars, exclusive breastfeeding decreases significantly. So we relied on data from the region to actually project how much the breastfeeding is going to decrease, and the increase in food insecurity, because actually the food conditions not only affects children, but also affects pregnant mothers because of their increased weight, increased caloric intake and caloric need. But also this also impacts elderly and different groups. But we also projected like the increase in food insecurity and how that impacts actually stillbirth and neonatal outcomes, and how mortality would increase because of that. So in terms of the results, like I mentioned before, in light gray, we show numbers of mortality before the war that would have occurred before the war for maternal, neonatal, and stillbirth. And then in the colored bars, we show the excess mortality in the next 6 months from lack of access to care. And I know the numbers, if you look at the numbers from maternal, they look low, in fact. And in fact, there's 28 women of excess mortality in an escalation scenario. But that's really what it means is actually going back in maternal mortality ratios that are seen in the past 20 years. So in 1996, we saw these maternal mortality ratios. The same if we look at neonatal mortality rates and stillbirth rates. And this is actually also an indication of a collapse of the healthcare system. And death of babies contribute vastly to years of healthy lives lost. And we know that the death of a parent also impacts significantly the children's future and survival. To show the same stuff but a bit differently is actually to show the gray line as a projection, and you can see that you have the projection before the war as gray, and then to date until February, this is where we were, and then based on the service coverage, this is how we're going under the 3 scenarios, whether it's an escalation in purple and whether it's a ceasefire in gray. And worth noting that given the toll it all takes, it will take time, even with a ceasefire scenario, to actually be able to go back to rebuild a healthcare system. To talk about finally NCDs, the NCD model, like I mentioned, is not all-encompassing, but NCDs was actually the major cause of death for the war. Gaza had very high prevalences of hypertensions and diabetic and diabetes. And we attempted to do something, although we know it's NCD is more complex, and so we opted for a way to show the minimum, but also knowing that this is an under estimation. So we included type 1 diabetes, chronic kidney diseases, ischemic heart diseases, stroke, and the cancers, whether breast, lung, and colorectal cancer. We used baseline mortality data in order to come up with and multiplied it by the relative risk of, and then what we ended up doing is changing the treatment. So what we did is we looked at the case of a treatment. What would be if you have access, if you're a chronic kidney disease patient and you have access to treatment, what's your survival? And then we also looked at if you're chronic kidney disease and not able to access hemodialysis, what happens in survival? And how many sessions you miss in survival. We did the same thing for cancer. We did the same thing for ischemic heart disease. So if you're having a heart attack, you don't have access to a hospital, what's your survival? And then we basically use this to actually come up with the excess mortality from NCDs. And in the same way as in the maternal, we show the bars in gray is what would happen before the war, and then the excess mortality is in colored. And you would see that one of the highest is actually ischemic heart disease. We're actually hearing a lot of that on the ground also, and mainly is because of due to access limited care of cardiac care. So people are going to the hospital and not being able to do any interventions to them, or even not reaching the hospitals on time. So ischemic heart disease is one of the main excess mortalities from that. Stroke, whether it's hemorrhagic or ischemic. We also looked at type 1 diabetes using data actually before the invention of insulin and the provision of insulin. And we use that, and mainly it's because of the lack of insulin and disruption of insulin supply. When we were doing this was actually becoming more of a problem. So in an escalation scenario, this would lead to very excess mortality. Cancer is mainly due to lack of treatment availability. Before the war in Gaza, cancer was already not treated well in Gaza and a lot of them actually required to go out of Gaza to get treatment. And so the delay in treatment and the lack of treatment and the lead to excess mortality. In terms of chronic kidney diseases, this is one thing that you keep on hearing. There are not a lot of chronic kidney disease patients and that need hemodialysis. However, the need for hemodialysis and 3 sessions per week and all of that actually, and lack of access to hospitals puts them at very high risks of mortality. And to finalize all of this is to say we did not project mental health, and maybe we will, maybe we won't, but just to say that Gaza had the highest burden of mental health diseases before the war, and the only psychiatric hospital was bombed back in November, and a lot of patients, around 480,000, are out of treatment, and 20,000 that need specialized mental health care are not getting them. Intimate partner violence is definitely a known issue in conflict and worth keeping an eye on. And this has a very heavy toll on children that are becoming unaccompanied. I think the number today from UNICEF is 19,000, not 17,000 anymore. And to say that these children who are 16 years old have lived through 6 wars in Gaza. So the idea of a post-traumatic stress is actually not really there, because this is a concept of trauma being repetitive and ongoing. as one of the lead psychiatrists in Gaza and Palestine, talks about Samah Jabir. And just to finalize everything and to say that we have done projections on traumatic injuries that basically we relied on heavy fighting periods. And things are increasing, but the reporting of the Ministry of Health decreasing as we move forward, mainly because of lack of availability to be able to record. And then in terms of a ceasefire scenario with an escalation, with an epidemic, around 11,000 mortality. Without an epidemic is around 6,000 excess mortality. And in an escalation, it would be around 85,000. And without an epidemic would be around 74,000. So just to conclude is that main cause of excess mortality is trauma. However, we are moving toward the infectious diseases being the lead cause. The more we move forward with the war, and infectious diseases with acute malnutrition is the worst combination, and where it would lead to even higher excess mortalities. And then just to say that the finalize everything actually and say that we would sorry, I changed the last slide, that's why I'm a bit lost. But a ceasefire scenario would also lead to an increased excess mortality due to lack of access, and a ceasefire now would actually lead to around 74,000 lives could be saved. So a further call into that. Thank you so much. I think I took a bit more time than I expected.
Yes, thank you so much. That is just an incredible body of work that you and your colleagues have accomplished in very little time. So I really appreciate you sharing your results and time with us today. We're going to move to the question and answer period now. We have a few that have come in that we could start with, Zeina. And then if others on the webinar would like to continue to add, please do. We have about 15 minutes left. So I'm going to go ahead and read the first question for you, Zeina, from Elijah. Elijah is a Brown University student, writing a paper on water insecurity in Gaza post-October 7th. He says that Israel has recently been flooding tunnels under Gaza with seawater, which many experts have warned will permanently damage the coastal aquifers' potability. What does this mean for the future of water accessibility and potability in the region going forward?
Yeah, Elijah, I'm happy to also discuss this more with you because we're currently looking at the water situation, more about what's happening with the desalination plants and all of that. But in terms of what would happen later on, it's exactly what you said. It's gonna be the infrastructure needs to be then rethought completely. I think I don't have a clear answer to you because it's what you mentioned. Sorry, but please email me because there's some work that we're trying to do on water insecurity and access to water now that maybe you are interested in.
Great, thank you. The next question is from Adam. Do you have any sense about if and when we will have all-cause mortality data for Gaza for the conflict period?
Yeah, I think, Adam, what happens in all wars, and also this one, but in all wars, is at the beginning, there's some good tracking, and as we move forward, tracking becomes worse. I know as a fact that there are methods that we've tried before in different wars where you could do capture, recapture, and some other elements that have been done in Yemen and Iraq. And to say that today, what I know what the Ministry of Health is doing is actually trying to come up with surveys to ask people to fill in mortalities of people that are missing. So people are reporting themselves. And there are methods to actually use these surveys to come up with how many people are missing. I think this will take on a bit more time. There are also methods of trying to do some estimates using scraping from social media to understand the mortalities that are not included in the Ministry of Health. And this is going to be, hopefully the war ends tomorrow, but this will be the big thing that people will try to estimate. And there are efforts that the Ministry of Health is trying to do to capture and patchwork the mortality that happened to date. But we'll need a ceasefire in order to come up with proper methods. I know UNICEF is also doing mortality estimates surveys. So information from here and there will give us a better picture, but not today.
Thank you. We have another question that's come in from an attendee that's really in two parts, Zeina. The first is a question around how these data influence the international humanitarian response. And then the second part of the question is that the question is whether this is a problem that can be feasibly addressed by aid, considering political implications and lack of accessibility to the population. So sort of two parts for you there.
Yeah, this is the biggest problem that we have shown these results. Like with WHO and others, everyone is on board. Even some people, like most people in the humanitarian sector, know what to do when wars happen. It's the political pressure that comes in and access to people, and especially in the north. What we were able to push more is for actually the food trucks. We have been in discussions to try to push for more food trucks coming in the north. The same thing is about what the same thing was just with WHO and others to try to see like what type of kit we need to understand surveillance, what would happen. So like really keeping an eye on cholera outbreaks, because currently today there's no labs in Gaza being able to do this. So stuff we know well in terms of surveillance are not working. So trying to push some of these elements in, hopefully with the ceasefire also with the more humanitarian access, we would be able to act more quickly. But in the middle of everything with the political implication it all takes and the accessibility to local communities, it becomes even more compounded, and you try to do with what you have. And this is the idea of, for example, if you talk about malnutrition, is like we're pushing for RUTFs and community management of malnutrition in the north, but it's very hard. Like very limited amount of boxes we're able to reach. Yeah, so it's what you said.
Thank you. I don't see any other open questions, but I actually have a related one for you, Zeina, which is a little bit more broadly. What has the response to the report been? Was it what you expected? Have you had instances where policymakers are directly engaging with your team to drive some of the next steps, or give us a sense on what it's like actually putting this out into the world and the response?
Yes, I actually different than the humanitarian actors who basically were all like, we know this, but thank you for doing that, and this is how we can plan funding for and what we need to focus on. In terms of what you're saying, political actions, I have to say that in the UK government, this has been mentioned and discussed multiple times. In the American, which I think is one of the key players in this, actually, we've had some senators reach out and we've presented it, and some of it has been also discussed in Congress by some different senators. So there has been discussions about the projections, but also the idea of what the scale could look like, especially as we talk about malnutrition. We have done an updated in malnutrition, and I really do think that these prevalences of malnutrition, 30%, are alarming in terms of like catastrophic in terms of the classification. But if this continues and we show with data, things are in an exponential increase at this point. And so we have been in discussions with also some partners have been in discussions with the authorities in Israel to also showcase these numbers and what's happening. So there's been multiple political discussions about that.
Thank you so much, Zeina. I'm not seeing any more questions.
And to be honest, sorry, if I want to say something, like, I think for me, like, this is the biggest thing is like, I don't want, today we don't want to be discussing with people who all see what's happening. We need to start showing these numbers to everyone to try to understand that this is not anymore linked to trauma, but also gonna be exponentially increased as we move forward. And I think that's the message that we need to try to bring to different actors on stage on. Yeah, sorry. Last question, I think.
I guess I might have one more question. Oh, we have one come in from Townsend. Could you talk more about how starvation conditions worsen along an exponential path? You mentioned this several times in the talk.
Sorry, I keep bringing this because it's more like, it's really what I work on the most now. So just to say that we have built a better model of malnutrition that we will be releasing. In fact, as the food availability from stores and from warehouses and everything available in Gaza is going down, the caloric intake is actually going down further. But at the same time, we have modeled now a new model, not this one, to try to see how much also parents are able to protect their kids. So we know that in food and extreme food insecurity, people will eat less to feed their kids. And so we use that. And then you start modeling how the acute malnutrition is increasing. Now, why do I say exponential increase? Because if you know the weight for height curves are actually a normal distribution. So it's actually like a bell curve. And a population of a bell curves actually is shifting towards more acute malnutrition is actually classified as less than 2 Z scores. So I'm sorry to be technical here, but just to say that this population is shifting in terms of their weight for height Z scores, so their weight over height ratio, shifting from this bell curve towards more of a more negative. And that shift actually is happening as we talk. And why do I say exponential? Because at a certain point, we're starting to see this increase that comes naturally from a bell curve. And so this is where I'm talking about that the population is moving towards a more exponential increase. Does it make sense? And I think happy to share when things are going more technical in terms of people are interested in the methods that we've done. But usually this is what we see in starvations. We see is that it's a whole population that shifts into their into bell curves, not a second of the population of the children. Talking about children, does it make sense? I don't know, maybe it doesn't, but thanks, Townsend. And just to add to all of that is this projection. Sorry, just to add to that, this projection is actually for 6 to 59-month-old of children. But 0 to 6-year-old children are super vulnerable given their decreased exclusive breastfeeding and decreased availability of infant formula, or the availability of infant formula with water that is very that's not clean. So basically, there's that element that also comes in for under 6 months old.
That's great. We're just about out of time here, Zeina, but what I've done is I put in the chat the link to the GazaProjections.org website, and I wanted to note to everyone that there is the full report available online, as well as a methods annex. So for those on the call that are interested in learning more details about the methodology, of which there are many, including pretty complex math underlying many of these models, those are available on that website and in the methods annex. So I just wanted to highlight that for folks. And thank you, Abdullah, as well, for noting that the webinar has been recorded and will be posted online in a few weeks, and we'll share that link publicly through our social media channels. So with that, I wanted to thank you again, Zeina, so much for your time and all of this incredible work you've done with your colleagues at the London School of Hygiene and Tropical Medicine and at Johns Hopkins. We really, really appreciate you sharing your work with us this afternoon. So thank you again. And the floor is yours if you have any last words for us to close out the webinar.
Thank you so much for the invite. I don't know who the audience has been. I don't know if it's more like students or faculty or how it's going, but just to say that this has been, in terms of a public health catastrophe unfolding in front of us, and we're always like trying to basically showcase in different ways what's happening. This was an attempt of doing something and we're trying to update it, but at the same time is to show the differences in whether a ceasefire and escalation, and to push our voices further into demanding for a ceasefire and for an unconditional humanitarian access to be able to save lives today. This has gone on a lot for a long time, 6 months, and I do hope that we're not here again in another 6 months talking about the same stuff. Because no, we won't be talking. If this continues, we'll be talking about we'll be seeing these projections happening, and I think we should be, as public health practitioners, pushing for when not seeing these projections come to play, but rather try to advocate for these projections reversal. So yeah, that's my last thing, is like to say that. And I'm happy to answer any questions. If anyone wants to email me, available. I might not respond quickly, but I will respond.
Thank you so much.
Thank
All
you.
right, thanks again for joining us. Zeina's email is in the chat if you would like. Thank you for offering that to follow up, Zeina. Really appreciate your time today. And take care, everyone. Thanks again for joining us.